I'll straight away go to the video. It's basically, I'll be showing the open carpal tunnel release. Amit had asked me to show only the open carpal tunnel release here. So this is the basic incision. This is the thenar crease here. And for all complications to be avoided, the most important thing is to be keeping ulnar to this thenar crease, about 6 to 7 millimeters here, ulnar to the thenar crease. So everything, if you stay at this level along the border of the ring finger here, the radial border, I think we can avoid a lot of complications. So this is where the Kaplan's lines will basically dissect, and this is the horizontal line here along the wrist crease here, thumb crease here. And then even during surgery, if I just, you get this ring finger here, that is the distal end here. So you should not be crossing that area and try to keep as much as possible in this direction. The carpal tunnel generally about 2.5 to 2.8 centimeters in length. So most of your incision should be only that. In case you want to extend, you need to go across at an angle at the wrist, and so that you don't cause any kind of a scarring at this point. Now, open carpal tunnel release can be two types. One is you can use the entire length of this in the palm, or you can use a mini incision. So I would insist that in the beginning, when people are doing this, they can use the entire incision and see the structures quite well, and then probably later go on to the mini incision of about just 1 to 1.5 centimeters. But this 2 to 2.5 centimeters length can be used most of the times to visualize the nerve nicely and do a good job, so that we don't injure any of these structures. So that is the basic extent of the incision. And once you do that, what you see is obviously the palmar aponeurosis coming in once the subcutaneous fascia is tissue is released. And below that would be your the transverse carpal ligament. So these are superficial fibers of the aponeurosis itself here. And I'm not extending my incision beyond this crease here at this point. And once you do that, clean up the whole area. These are the fibers of the aponeurosis here. And then start dissecting, or rather teasing out all these fibers slow, so that you go towards the transverse carpal ligament. And sometimes you would see a small amount of muscle fibers here. Sometimes these are these actually palmaris brevis muscle here. And you would see that sometimes the muscle can be quite thick actually, or sometimes it could be just a few fibers of these palmaris brevis. I'm staying here in the proximal aspect because the dissection should start from the proximal aspect and then go towards the distal side, not the reverse way. So this is just below the muzzle here is the transverse carpal ligament. And you make a small cut there to see this nerve here. You can see the change of the color there, and the nerve pops out at this point. So that's a small incision you need to make. Be very careful there. The moment you make that incision or open, then the entire dissection should be based on this protecting the nerve through and through with any of these elevators, or a kind of this is a McDonald's retractor I'm using here, and everything has to happen over this. So throughout the procedure, you need to protect the nerve and not directly use your knife here. I never use 11 number knife. I always use a 15 number knife for this. So through and through, so keep taking it out and repositioning this, because distally the nerve becomes more thinner and flatter. And so you need to reposition it as you go towards the distal aspect. The distal aspect of the transverse carpal ligament is quite thinned out. It merges onto the fascia here. So it can be very thinned out. It may not be a very thick edge here always. So be careful with that. Once you start seeing the fat coming in, that means the nerve is branching out near that area. And that is where you need to stop your dissection and make sure that you see the nerve nicely, retract the nerve, and if at all there is. So that is a thick edges of the transverse carpal ligament, both sides, which is cut now. And you need to release the deep fascia, the forearm fascia from this side. So you just have to palmar flex the wrist about 30 degrees and go in there, and under vision, you just release that. You always get a giveaway feeling here. Retract the nerve gently onto whichever side it is easy. So basically, I want to see if there's anything else here. Sometimes the nerve, the digital branch of the thumb can be in a very separate compartment. Patients can have deep aching pain in this. So sometimes that has to be released. So check on the tendons, see for any synovial thickening like this. sometimes this patient was a case of rheumatoid arthritis. That's why we did an open release. Otherwise, I routinely do an endoscopic carpal tunnel release, and always check the floor of the tunnel and make sure that you don't have any surprises. There could be ganglions here or any of these anomalous structures. So always check that. Now, if you want to extend the incision, as I said, always go crisscross at an angle here. Don't go straight, which will cause very bad scarring at the wrist crease. And this patient, as I said, was a patient of rheumatoid arthritis, and we wanted to do a synovectomy and also send it for biopsy. So we just had to extend this in this manner. And we go towards the forearm here, and then, remove this. So here your palmar-cutaneous branch would come on the radial side. You don't really look for it, but you need to be careful if you're dissecting at this area. So usually it's on the radial side. So there is a nerve. So if you see, this is the thickening of the nerve. So this is the flattening here. This is the broad nerve. This is what the actual picture will be in most of the very bad old carpal tunnel compressions. The nerve is on the side here. This is all the tenosynovium, the synovial hypertrophy over the tendons. So we wanted to do a timed tenosynovectomy of all these tendons here. The nerve is always retracted to one side, and your assistant full-time holds onto it. And so tendon by tendon. So you have the FPL, then you have the flexor superficialis, digitorum superficialis tendon superficially, and then you have the FDP below. So each of these tendons you pick up, and then you can do a thorough job. Synovectomy in rheumatoid patients actually reduce the load of inflammatory tissue, and that is very, very important for their pain relief also. And it's a very easy way to reduce the load for these patients. And sometimes if there is not a clinical diagnosis and you have a lot of these synovium, you might have to send it for biopsy. Sometimes it could be tuberculosis and other kind of granulomatous conditions. So meticulously remove all these things, all the synovium there, and then check on each of these and make sure that you're not damaged any of these. And sometimes there could be anomalous tendons, anomalous muscles, the nerve. So many things can happen here. The nerve could be bifid median nerve. It could be branching very proximally or very distally. And then there could be interconnections between the ulnar nerve and median nerve. So there could be so many kind of anomalous things which can happen. And so this is the FDP portion of the carpal tunnel. So you have 9 tendons and 1 nerve. So you need to make sure that all of these have been checked thoroughly. Okay, and that's the FPL there. And that's the lumbrical there. And sometimes the lumbricals can be originating very proximally here. And that is the floor of the tunnel itself. So at the end of it, you need to check the floor of the tunnel and make sure you don't have any kind of swellings or any of these. And the most important thing is this first stitch where you do an apical stitch here so that you get the wrist crease back for the patient. That's very, very important. So you go through the skin here, go to the subcutaneous tissue here, and come out of the skin here at this point, and make sure that this wrist crease is nicely formed where your line is there. That apical stitch is very, very important for you to get a nice wrist crease back for this patient. And that's how you end this procedure here. And then we usually sometimes immobilize for a week with a slab and then start mobilizing these patients quite early. Endoscopic release, again, we immobilize quite fast. And my main reason for doing an endoscopic release is basically that there is absolutely no scar in the palm. The incision is basically in the distal part of the wrist crease, the forearm, and that is one reason I like to do endoscopic. Otherwise, it's always an open release whenever indicated for patients with these kind of synovectomy or any other procedures. Thank you.